Hi everybody, my name is Amanda Dreyer from beautifulnursing.com. I am so excited to come here today to tell you all these big concepts and things you should know before starting your first semester of nursing school. I know that it's a very exciting time getting accepted into nursing school, but also worrying about, what you should know to feel confident going into your first semester. So I am going to go over all the big concepts and topics that you're probably going to talk about in your first semester and break them down so you can feel like the smartest person in the class. Let's just get started. I really hope you guys enjoy this. So one of the first things that you're probably going to talk about in nursing school is the nursing process. This is called ADPIE, and what that stands for is assess, diagnose, plan, implement, and evaluate. This is a process that you're going to use in almost every single patient encounter. As the nursing student, when you walk into a patient's room, the first thing you're going to do is assess the patient. You're going to look at their vital signs, you're going to ask them questions, you're going to do your head to toe examination, so you're collecting all this data from the patient. Now there's something important that you should know, that there's two different types of data. There's subjective data and objective data. So subjective data, I always remember this as subject to change. So there are things that, the patient might tell the nurse or the family or friends might tell the nurse. Whereas objective data is data that the nurse observes. So this could be their vital signs, this could be the patient's EKG, or if the patient is trying to raise their arm and they start to grimace. So this is information that the nurse will observe. So that's subjective versus objective data. So once you collected all your evidence and data from the patient, the next thing you're going to do is diagnose. This is like a Nancy Drew mystery where you're collecting all these pieces and you got to figure out what's the problem here, what could be causing this problem for the patient. So you're going to come up with a priority problem that would usually align with your nursing diagnosis. So you're going to get a book that's usually by Nanda, like this huge list of nursing diagnosis that you can use in your care plans, which you'll learn more information about. But that is that stage of the nursing process, which is diagnose. So in the next stage of the nursing process is planning. So this is where you're actually going to start to think about, what am I going to do to fix this problem? Now that you've diagnosed what the problem could possibly be, you got to think about, what can I do to fix it? And that is where you start to come up with goals to fix the patient's problem. And then you're going to do implementing. So implementation or implementing is actually doing nursing actions that could solve the problem. So this could include, raising the head of the bed, getting the patient some fluids. In the final stage with evaluation, you're going to see, okay, did my nursing goals and actions, did they actually help the patient problem? And if not, what can I change? So again, that is the nursing process. You're going to assess, diagnose, plan, implement, and evaluate. So let's move on to lab values. Lab values are something so important. You need to know these in every semester of nursing school. You should know these for the NCLEX. So I made a really funny TikTok that I hope will help you remember. So here you go. Well, I'm getting another call. Student nursing fairy godmother speaking. Lab values, of course, I can help with that. Potassium, the number of bananas you buy from a store, 3.5 to 5. Fluoride, it usually has to be at least 95 to 105 degrees to go swimming in a pool. Hemoglobin, think puberty. Males, 13 to 18. Females, 12 to 16. Females usually go through puberty first. Magnesium, think of magnum. Okay, these are for men that are at least 1.5 to 2.5 times bigger. Finally, bun levels. If somebody has a nice bun, usually they're a perfect 10 to 20. Student nursing fairy godmother speaking. More lab values, of course I can help. Calcium. You're reporting a theft from a red-headed mermaid? Calcium. Call 911, 9 to 11. phosphate fossils. Oh my god, these are 2.5 to 4.5 million years old. Creatine. He is a creatine creature. On a scale of 0 to 10, he's definitely a 0.5 to 1.5. White blood cells. Kids ages 4 to 11 are always getting sick. Achoo! Really? Sodium. This is absolutely delightful. This can of cola only cost me $1.35 to $1.45. $1.35 to $1.45. Hi, Dr. Mike. Did the patient's PT and INR results come back?
The patient's PT and INR is 11 and 1.
Okay, cool beans. Siri, what is a normal PT and INR?
You should have paid better attention in nursing school.
Well, that's not nice. Hi, yeah. Well, until my daughter's back in school, I was just hoping to work, like part-time hours, so like 10 to 12 hours a week, if that's okay. Please. Addison, I'm so excited. My Visco stickers come Tuesday. And is it just me, or is Justin Bieber like low-key kind of cute? Okay. The I in INR looks like a 1, so less than 1.2. Hi kids, my name is Amanda and I'm going to be your nursing instructor. But before we begin, everybody wish me a happy birthday because I am turning 35. Almost 40. Alright, so in the first few weeks of nursing school, something else that you're going to learn about is taking vitals and normal vital signs. So we're going to talk about the different types. The first thing is temperature. So everybody probably knows that a normal temperature is 98.6 degrees Fahrenheit, but there are different ways to take temperature. So oral, which is through the mouth, this is the most common way. You put a thermometer in and you get a temperature. The next way is axillary. This is under the armpit. This is going to be less accurate. Usually it runs lower. You have tympanic, which is the ear, a temporal forehead scanner, and then finally rectal. That is a different way that you can take temperature. Just make sure that you're not taking a rectal temp on somebody with diarrhea. And if you do a rectal temperature, make sure you lube the end of the thermometer before inserting, because otherwise it could be painful for the patient. All right, so the next thing you're probably going to learn about is pulse, how fast the heart is beating. So when you are taking a pulse, let's say you're going to do a radial pulse, you're going to use 2 fingers, follow the thumb, and you're going to feel how many times you feel that pulse within 1 minute or 60 seconds. So a normal pulse for an adult is that 60 to 100. The fetal heart rate is 110 to 160. Newborns can be 100 to 160, and children can be 80 to 120. So if you guys notice, as you get older, the pulse usually goes down in its rate. Another thing you can learn about is pulse strength. So let's say you see on a form somebody marks down that a pedal pulse is +1. What does that mean? So 0 usually means that it's absent, it's not palpable, you can't feel a pulse. 1 is going to be it's weak, it could be thready. 2, this is considered a normal pulse. You feel it, it's not super strong, but it's easy to palpate. +3 is usually that it's strong. It's a stronger pulse, it's increasing. And then finally +4, this is going to be where it's the strongest pulse, it's bounding. All right, so the next thing you're going to learn is how to take a blood pressure. Blood pressure is how hard that your blood is pressing against those vessel walls, right? So a normal blood pressure is going to be 120 systolic over 80, which is diastolic. If you guys remember from A&P, systolic is your heart contracting, right? Whereas diastolic, I always remember it so it's not doing anything. Your heart is relaxing, diastolic. Is elevated is 120 to 129 over 80. Hypertension stage 1 is going to be 130 to 139 over 80 to 89. Hypertension stage 2 is going to be 140 or higher or 90 or higher for diastolic. And then finally, a hypertensive crisis is going to have a systolic 180 or higher, or a diastolic blood pressure of 120 or higher. So some terms to know with blood pressure is hypotension, which is low blood pressure is hypotension. Hyper is high blood pressure, whereas orthostatic hypotension is going to be when a patient is in a lying position and maybe they sit up or stand and their blood pressure drops. So that is considered orthostatic hypotension. Oxygen saturation, you're gonna put on a pulse ox on their finger. You don't want it to have nail polish on their finger. Normal oxygen saturation is usually 95 to 100%. Respirations, this is how fast a patient is breathing. So usually when you're doing this in lab, you're gonna look at how many times that their chest will rise and fall within 1 minute. So a normal respiratory rate is 12 to 20. A newborn respiratory rate is 40 to 60, infant is 30 to 50, and children is 20 to 30. All right, so some terms to know with respirations. The first one is tachypnea. Tachypnea. So that means that it is a fast respiratory rate, and then bradypnea is a slow respiratory rate. And then finally, dyspnea, which is difficulty breathing. Finally, a lot of people consider this another vital sign, which is pain. So this is something I remember that I did look up before my first semester of nursing school. So when they asked this question in simulation, I was so proud of myself. I felt like I looked so smart, even though I was super unconfident. So something you should know is old carts, or OPQRS. So let's go over old carts first. This is something you can use to assess a patient's pain. So it's going to be onset, location, duration, characteristics, aggravating factors, alleviating factors, radiates, treatment, and severity. Okay, and then another one is that OPQRST. So O is for onset, P is for provoking or palliating factors, Q is for quality, R is for region, S is for severity, and T is for time and treatment. So you could use either one of those. I personally like old carts, but they both work. And again, this is to look at the patient's pain and kind of assess exactly what could be going on. So the next thing is patient positioning. I have a really funny TikTok to hopefully help you remember the different types of positions, and we'll come back here. Supine on my spine. Away from that tailbone. Sims, a pillow under the leg and under the arm. This is the actual position that I'm in when I play The Sims. Garrett lost his job. Lateral. Let me just roll onto my side. Lateral. Dellenberg, that sounds like a backwards 1800s old school name. Gotta go backwards, honey. Feel like a baller and semi-baller. Supine on my spine. Prone, away from that tailbone. Something you should know with Fowler's or sitting up is that there is low, semi, and high. So low Fowler's, so that'll be considered 15 to 30 degrees, whereas semi-Fowler's is going to be 30 to 45 degrees. And then high Fowler's is usually that 60 to 90 degrees, or, sitting completely upright. All right, so now I'm going to go over the basics of medication administration. So when you are administering a med, you have to be a safe nurse. And in order to do that, you do what is called the rights of med admin. So the rights, I have a cute little way to remember what they are, is that patients do drugs round the day. So that stands for the right patient, the right drug, the right dose, the right route, the right time, and the right documentation. And when you are administering those meds, there's different ways that you can do that. IM, which is intramuscular, so into the muscle. Usually this is done at a 90-degree angle in the deltoid or arm, the ventrogluteal, which is the buttocks, or the vastus lateralis, which is the thighs. There is subcutaneous, so this is something you're going to see a lot with insulin. So you're going to take a part of the body that has a lot of fat on it, so like the back of the arm or the abdomen, and you're going to do that at a 45-degree angle. You have IV, which is intravenous or into the vein. So usually that's done around a 25-degree angle, and there's many different sites that you could do an IV, but one of the most common is the radial or cephalic vein. So again, when you're doing IV, it's into a vein. And finally, intradermal. This is something that you're going to see a lot with TB tests, or mantos as they're called. So this is going to be at 10 to 15 degrees. It's going to be, pretty much on almost the epidermis of the skin. So it's the surface of the forearm or the upper back. Other routes of administration besides PO, which is the mouth, you can have the ophthalmic, which is the eye. You can have topical, which is the skin. So topical is just the skin. Or you can have otic, which is the ear. All right, so another thing about medication administration is that there's different types of orders that you could receive. So you could have something that says PRN, so that means as needed. Great, so something else with medication administration is that you can get different orders for meds, meaning that it could say PRN, which means as needed. So an example of this that I see a lot in practice is acetaminophen, right? You can give the patient acetaminophen for pain, or if they're having a fever, as needed. And sometimes it'll even come with, what would qualify the patient to need that medication. So if they are showing a pain level of over 6, give them this medication. So again, PRN is as needed. You have a single one-time prescription, so something that you're only going to give to the patient once. It's not a reoccurring medication. Routine or standing prescriptions, so these are medications that the nurse can give on a routine basis, or like a regular schedule without a expiration date. So you're going to just continually give these routine or standing prescriptions. Thing called a stat prescription. So it sounds just like what it is, that you need to give this medication as soon as possible. Usually these are prescriptions you see more in emergent situations. Stat is something you give once, and usually you give immediately. And then finally, if you are going to be taking an order over the telephone for a medication, you want to make sure that you always read it back, because sometimes if you're like me, it can be hard to hear on the phone. So I always have to verify that I heard the correct thing. You have to repeat it back to the doctor, because you might have heard something wrong. Some medications can sound very alike. So again, just clarify if you got it correctly. Again, if you really are struggling with hearing what the provider is saying, just pull a second nurse and see if they can listen on the phone. Just make sure you do it though in a secure area, because you want to make sure you comply with HIPAA, which you'll talk more about. So another thing you're probably going to learn about in your first semester is something called Maslow's hierarchy of needs. This is something very important to know because if you're trying to decide which patient's room should you go into first, or trying to answer a nursing exam question or the NCLEX, you have to figure out, which one is more of a priority. So Maslow's hierarchy of needs has these different levels. So on the first level, you have the physiological needs. This is going to be food, water, oxygenation, sleep. So those physical needs that the patient might have. And then you have the safety needs. So this is security, safety, maybe a patient is falls risk, make sure that they are safe. So the next one is belonging and love needs. So this is going to be like their relationships, their friends. And you're going to have their esteem needs, which is like respect, strength, freedom, and then finally like self-actualization. Again, when this is coming to priorities, this would be the last priority of making sure that the patient is like achieving one's full potential. You need to prioritize patients' physiological needs first over their safety and security, belonging, esteem and self-actualization. So again, going back to priorities, so when you're in that physiological needs, looking at those of a patient, you also want to use something what's called ABCs, right? You might have heard that if you've ever watched Grey's Anatomy. So again, something you might also use to prioritize care for a patient to see which one you need to go check on first is using your ABCs. ABC stands for airway, breathing, and circulation. So an example of airway would be if somebody has something that's blocking their airway. They cannot get air in or out. That is a medical emergency. You need to intervene as soon as possible because they can't get air. Breathing, again, that is kind of in that category. The patient might have an open airway, but again, they're having difficulty with breathing. You need to prioritize that. And then finally, circulation. So is the patient having signs of a clot? Or, is the patient having trouble getting blood to a certain area of their body, right? So you need to look at, again, use your ABCs to prioritize which patient needs your help first. So then there's different levels of healthcare. So you have primary, secondary, and tertiary. A way to remember primary is with the P's, primary preventative. So this is doing things like talking about smoking cessation or nutrition or exercise, things that will help enhance the patient's health. It is a preventative manner, whereas secondary is where you already suspect something might be wrong. I always remember with the S's, secondary screening. So this is doing like a breast cancer screen or doing some blood tests to seeing, thinking there might be something wrong. So secondary screening. Tertiary is that last level of healthcare where the patient is already sick. So maybe they have a chronic illness or disability and they require care from the nursing team because they are already diagnosed with something. So tertiary care. All right, so now we're going to talk about medical and surgical asepsis. So asepsis is the absence of illness-producing microorganisms. And there is a difference between medical and surgical asepsis. So medical asepsis is reducing the number of microorganisms, whereas surgical asepsis is the elimination of all illness-producing microorganisms. You're probably going to get this on a test question, but know that the number one way to prevent the spread of infection is with proper hand hygiene. So with asepsis, there's something called a sterile field. So what that is when a nurse is doing a high infection risk procedure like a tracheostomy care or a catheter, you have to make sure that there's an area where you are performing this procedure that is staying sterile. So it is going to prevent the patient from further complications or illness. So these are the guidelines for sterile fields. So the first one is that only sterile items can be in the sterile field. Any material that goes below the waist or above the chest is considered contaminated. Do not reach across a sterile field. I remember that when I was first practicing doing a tracheostomy cleaning, that I reached across and I got nicked on that, so I had to redo it. So do not move across the sterile field or turn your back on the sterile field, because then that stuff on there is considered, again, contaminated. The outer 1-inch border of a drape is considered not sterile. You also want to make sure to keep the sterile field dry. If you find when you open up, this catheter kit or something, and you find something's torn or wet or punctured, that is considered non-sterile. So you want to discard that and find some new materials. Again, with the topic of safety, we want to talk about safety precautions. All right, so I have this little TikTok that I made on the different safety precautions of what type of illnesses require which safety precaution, and what equipment you might need to make sure you are keeping yourself and the patient safe.
Go to room 2. Suit up, they have measles.
Which safety precaution is that? Standard. They're for everyone. It's like, where's Waldo? Okay, girl, drop it like it's hot for your... Ooh, come on, guys. Do not come into contact with anything in this sewer. Unless it's a Ninja Turtle. Hi, welcome to MTV. Oh my gosh, thank you so much for flying all this way in the air. We even got you a private room and hooked you up with a real sexified mask called N95. All right, so just going over again what equipment you might need for different illnesses. So if you have a patient that's on airborne precautions, you want to make sure you go into that patient's room with an N95 mask, and you also want to make sure that patient has a private room, or that they are sharing a room with the person that has the same exact safety precautions. So it could be a measles patient with a varicella patient. To a patient that is on airborne precautions, they're going to have a negative air pressure room, and if you do for any reason need to transport that patient out of the room, they should be wearing a mask when they leave or exit any time out of that room. If the patient is on droplet precautions, this again, the patient should be in a private room, or if they have a semi-private room with somebody else that also is on droplet precautions. But it's very important that the nurse is wearing a surgical mask, and that the patient should also wear a mask when they are exiting the room. And if you have a patient that has contact precautions, you're going to have them in a private room or semi-private, again, if they are sharing the same exact type of precaution. So 2 contact precaution patients. And then you also want to make sure that as the nurse, you're wearing gloves and a gown, and you're going to have to use disposable equipment, because you do not want to, have your own equipment get contaminated and then spread that to everyone else on the floor. With contact precautions, it's very important to have very good hand hygiene when you enter and exit the room. Also, when you're caring for the patient, hand hygiene is very important. And then for patient safety, we're going to talk about if you put a patient on seizure precautions, what that means is that you should first and foremost time the seizure, because it's very important on what kind of treatment options are going to be available for the patient. But next, you also want to provide privacy for the patient. You want to make sure their bed is in the lowest position. You want to make sure that their side rails are up and that they are padded. You also want to make sure that there's nothing in the patient's mouth. You don't want to put a tongue blade in there. There's a risk for aspiration. So make sure nothing is in the patient's mouth. You want to have suction and oxygen available at the bedside. Also really important that you put the patient on their side and loosen any tight clothing, and making sure that you're keeping watch on the time with that patient's seizure. All right, so then on the other hand, if you have a patient that is considered a high falls risk, you want to keep them safe too by making sure that they have a room close to the nurse's station, by making sure that they understand how to use their call light. Some patients even have color-coded wristbands that say that the patient has a high risk of falls. It is important too that you look at their footwear, have them wear non-skid socks or shoes, as well as having a non-skid bath mat. As far as the room too, having them close to the nurse's station is helpful, having the bed in the lowest position, having items, that they use frequently, like a telephone or their water, to have that within reach. And it's very important that the nurse has like an hourly rounding schedule in case the patient needs help with, getting to the bathroom or ambulating. And so when the nurse does go in the room to help the patient, make sure you always use a gait belt because that will help too if a patient does start to fall, and the nurse can kind of grab the gait belt and help them get back up. So those are all important interventions that you can use if you have a patient that is considered a high risk for falls. And then finally, we're going to talk about if there is a fire. Beep, 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 beep. What do? Just remember the word RACE. RACE stands for Rescue and Protect Clients. A is alarm, so you want to pull that alarm. C stands for contain or confine the fire by closing doors and windows, making sure you keep the fire in one area. And then E stands for extinguish the fire if possible. And so if you are going to use a fire extinguisher for the first time, just remember PASS. So PASS stands for pull the pin, aim, squeeze, and then sweep. So we want to make sure we get all that fire out and keep everyone safe. All right, so let's talk about nursing ethics. Ethics, right versus wrong. So when you are in practice, sometimes you're going to be put in situations where you're not sure how to respond or how to act. So there's different principles that can help guide you into what would be considered the most ethical manner or response to something that happens.
Choose your courage.
So one of the ethical principles that you should know about is autonomy. Autonomy is allowing the patient to make their own healthcare decisions. All right, so the next one is beneficence. Beneficence is to do good. It kind of sounds like beneficence, beneficial, right? So you're doing something good for the patient. Non-maleficence. I always think of Maleficence, the evil queen. So doing pretty much opposite of what she would do. Because as a nurse, you vow to do no harm. Non-maleficence. There is fidelity, whereas making promises to a patient. So if you say, hey, I'm going to be back in 15 minutes, that you are going to try to keep to your promise and come back in 15 minutes. Veracity is telling the truth. So sometimes it can be hard to say the truth to people even when it hurts, but it is ethical to tell people the truth even in the hardest situations. So veracity is telling the truth. Justice is like being fair by providing the same type of care to all patients regardless of who they are, their race, gender, background, beliefs, whatever it is, that you are being just and fairly providing care to everyone. That most people will experience in nursing is loss. So you will see this a lot of people losing their friends, family, significant other, which is never easy. And there are different stages that a patient usually goes through when they experience grief or loss. And so it starts with denial. The client could have difficulty believing the reality of the situation, so they are denying that this situation exists. So this is usually if a wife loses their husband, they'll say, oh, he's not dead, go check right now, he's just fine, I just saw him breathing, he's totally fine. And the next one is anger. So after, you know, you're denying it, you're gonna start to feel angry, like, no, this didn't just happen, that can't be right, you know. Like starting to get angry maybe at yourself or at others, whatever it is. After anger is bargaining. And in this bargaining stage, this is usually when a patient will try to negotiate for more time or a cure for somebody that they might have lost. And then depression is when they start to feel very sad, very low. The client will be overwhelmingly saddened by the situation. It starts to finally kind of hit them and they go into this depressive state. And then finally, acceptance. This can take patients months to years to finally reach this stage in this model, because it really depends on what they went through. But acceptance is where, you know, they acknowledge what happened and they are finally planning on the future. They're moving forward. They're kind of getting over this incident that happened, and they're just looking forward to what's coming next. It's really important to know that people can experience grief in different ways. People can go through these different stages at different times in their lives, and as the nurse, just make sure that you are showing empathy and being there for your patient as much as possible, because it can take time to finally reach that stage of acceptance. All right, so let's talk about triaging. So there is a triage system of having tags with red, yellow, green, or black that was developed for emergency situations, or if you're having a high influx of patients. So the first one, which is a red tag, this would be given to patients that have sustained life-threatening injuries and require immediate treatment. So these are people, you know, maybe with a gunshot wound or they're hemorrhaging and they need immediate assistance in order to survive. Then the next would be considered yellow. So yellow is patients that have sustained major injuries, but they're not usually life-threatening. So these patients can be seen usually within like 2 hours, but they should still be reevaluated every half hour. Okay, and then there's a green tag. So a green tag is considered patients that have sustained minor injuries that are not life-threatening. They're called walking and wounded, and these patients can go hours to like a day without being seen usually and would still survive. Finally is a black tag. This is considered the lowest priority patient because usually they are either already dead or they are pulseless or breathless and do not have a chance of survival. As sad as it is, usually these are the patients too that you just don't want to waste your resources or labor on because they are considered kind of already dead and can't be treated. So you're gonna give that patient a black tag. All right, and so to quickly talk about delegation. Delegation is when you transfer a task over to someone else, but you are still held accountable for the outcome. So you might give somebody else, a task for them to do, like taking vital signs, but if that doesn't go well or it goes right, you still are accountable for what happens. So as the nurse, there's different types of nurses, right? There's a registered nurse, there's a licensed practical nurse, there's certified nursing assistants, and they all have their own specialized skills and knowledge that make the interdisciplinary teamwork, right? We all bring our own stuff to the table. But it's very important that when any of these members of the team delegate another task to somebody else, that you are making sure that it is to a stable patient that has a predictable outcome. So the rights of delegation are the right task, the right circumstance, the right person, the right direction and communication, and the right supervision and evaluation. It's important too for a nurse to understand the scope of practice, what people are allowed to do in their positions of a registered nurse, a licensed practical nurse, a CNA. All right, so let's talk about oxygen therapy and the devices that you can use. I have a funny little TikTok that again is just using mnemonics to help you remember the different types of therapy for oxygen delivery methods. Non-rebreather. Oh my gosh, they are not breathing. We gotta give them 10 to 15 liters per minute of oxygen. This is emergency. Chop, chop, people. Can you put this in the nasal? This is usually used for maintenance, 1 to 6 liters per minute. Nasal cannula. Partial rebreather. They can partially breathe on their own. It looks very similar. We give them 6 to 11 liters per minute. Venturi, or as I call it, Venturney, because you can turn this to be very precise and give 4 to 11 liters per minute. Venturi. A simple face mask for more simple issues, like if they're dizzy or a minor bleed. So 5 to 8 liters per minute. Okay, and finally, a face tent if you have facial injury or burn. So I want to talk a little bit about elimination. In my first semester of nursing school, I felt like we talked about bowel movements probably half the time. The frequency of bowel movements can definitely vary on the patient, but the average patient will have one bowel movement every 1 to 3 days. Different types of bowel movements. There's constipation where you have difficulty with having a bowel movement, and if they do have a bowel movement, it will come out as hard, right? Because they are having trouble passing it. On the opposite end of that, a patient could be experiencing diarrhea. So that is more liquidy stool. Laxatives is one of the biggest used and abused drugs in the geriatric population. It's important that you educate the patient on how there are ways outside of pharmacotherapy that can stimulate a bowel movement. So that includes increasing water intake, exercise, and increasing the amount of fiber in the diet. Other key terms to know is, again, diarrhea is like a liquidy or loose stool. Flatulence, that is gas. Constipation is difficulty with bowel movements. Impaction is going to be that mass of hard stools that you cannot pass. Obstruction is a blockage of foods, fluids, gas, or gastric acid in the large or small intestine. And so let's talk about bladder. It's important to note that less than 30 milliliters per hour of urine output is considered concerning. So if you have a patient that you see on their, fully catheter, or if they have one of those hats, when you're measuring their urinary output, if you see less than 30 milliliters per hour, it can be the sign that there's some kind of blockage or that they're having some kind of infection that should be managed. So when we're talking about the lifespan of urinary elimination, when a baby is born, usually they'll have about 8 to 10 wet diapers a day. So around the age of 3 is when children will start to be able to go to the bathroom by themselves and have more of that independence. In older adults too, you'll see that they're having a decreased renal function, bladder contractility, their urine can be more dilute. There's decreased bladder muscle tone, so that also gives way into urinary incontinence. There are different types of urinary incontinence. There is stress incontinence, so this is urine loss from sneezing, coughing, lifting. This is very common in women like me, hint, hint, that are post-childbirth, and if you make me laugh too hard, I have to go change my pants. So that is stress incontinence. There is overflow incontinence. That it sounds just like what it is. It's overflowing because you do not completely get all the urine out of your bladder, so you have little dribbles of urine throughout the day. This can be due to a spinal cord injury, multiple sclerosis, or an enlarged prostate. There is transient urinary incontinence. This is reversible. This could be due to an infection or medication. Urge incontinence, so you have that urge to go, but you just can't make it. So these are people that all of a sudden feel like they really have this urge to go to the bathroom, but you don't make it to the bathroom. This could be caused by UTI or overactive bladder. Reflex incontinence, where you have no sensation to void. Again, that could be from a spinal cord injury or multiple sclerosis. This one is functional incontinence. So this patient might be experiencing impaired mobility, where they cannot make it to the bathroom and they have that loss of urine. Phrases that you should know for elimination in urinary incontinence is oliguria, that is less than 400 milliliters of output in 24 hours. There's anuria, which is less than 100 milliliters of output in 24 hours. Remember the ends, nocturia, nighttime. So nocturia is nighttime incontinence. Dysuria is difficulty with urination. So let's finally talk about wound care. So when you are caring for a patient that has an injury or some kind of wound, there are different phases for wound healing. The first phase is the hemostasis phase. So this is when the blood vessels constrict. They're like, oh my gosh, there's open skin here. Let's quickly constrict those blood vessels, try to control the bleeding, and it moves platelets to that area. So platelets come together, try to make it clot again to stop the bleeding. And there's the inflammation phase. So this is when, you'll start to see the wound have heat, swelling, redness, pain, in that site of the wound, and the immune system just starts to send white blood cells over to that area. And then in the proliferative phase, I always think of this as proliferative, the prolific time to fight back when we make new cells. So new cells are starting to form, collagen is being laid. Final phase, which is remodeling. It is what it sounds like, remodeling phase. That's when scar tissue changes appearance to the surrounding skin. Collagen strengthens the scar and skin integrity becomes intact. So this wound is starting to close in this remodeling phase, and it is starting to be like it never happened. Talking about wounds, let's talk about the stages of pressure injuries. Pressure injuries can occur when patients are in one position, putting too much pressure, usually on their lower back. So that's where you see them most of the time. And there's different stages when it comes to pressure injuries. First stage of pressure injuries, you are going to see erythema or redness of that area. So it's going to be red, it can be swollen, it can be warmer or cooler than the surrounding tissue around there, but that is stage one. Then in the second stage of pressure injuries, you have partial thickness skin loss with loss of dermis. So the wound is still going to look kind of pinkish to reddish. It can appear almost as intact or as a ruptured blister. Stage 3 of pressure injuries is full thickness tissue loss. So in this stage, you're going to see adipose or fat, can be some slough or eschar present. The wound edges can appear rolled under. But at this point, there is no exposed bone, muscles, or tendons that are seen in this stage. Last stage of pressure injuries, this is going to be considered full thickness skin and tissue loss. This is when you're going to see exposed bone, tendon, ligament underneath. There's going to be eschar, there's going to be tunneling, undermining. So you get to higher stages with pressure injuries, you also have an increased risk of infection. So people that do have exposed bone or tendon, or the tissue loss, you want to make sure that you are keeping that wound clean and dry so you can promote wound healing. Because promoting wound healing is very important as you get into these later stages of pressure injuries, and also keeping the patient free from infections. And some other terms to know with wound drainage is serous. Serous is watery drainage. Sanguineous is going to be bloody drainage. So if you hear the word serosanguineous, that's just a mixture of both of them. So it's going to be watery with blood in it. So it could be a pinkish tint. purulent drainage. This is infected yellow drainage. Usually it has white blood cells, debris, bacteria in there, so it's infected. And then purosanguineous is pus and blood. So delicious. General terms with wounds is that if you have a wound that is desiccated desert, I always think, because it's dry, whereas macerated is opposite, macerated moisture. If a wound is macerated, it's overhydrated. It could be kind of whitish because it's an over moisture of the skin. Dehiscence is a partial or total separation of a wound. Edema is just considered swelling. Usually there's fluid there, so fluid swelling with a wound. And then peri-wound is skin surrounding a wound. It's a bad situation out there. Come on, bring it all. Oh, my sock is drenched with too much water after coating that patient. Time to get it out. Can someone get me some hypotonic fluids? We gotta dig those fluids into the cells. Hey guys, I really hope you enjoyed this review, and congratulations on getting into nursing school. I wouldn't trade my time there for anything in the world. I learned so much. I came out a different person, and I have made friends for life. So don't listen to all the negativity on the internet. Just focus on you. Focus on all the patients that you are going to change their lives, to make their lives better, because it is a great profession. So I wish you guys the best of luck. Have a good day. Bye.